days to go now?
Last 2 weeks.
She's excited.
Yeah, like.
Good evening. Welcome to the special 200th episode of iFocus. We'll have a little bit of celebrations next week, but for today we have a celebration in the sense that Dr. Taraprasad Das is here with us. He is one of the doyens of Indian ophthalmology, and endophthalmitis is his area of special interest, and he'll be speaking to us on that topic. Over the last 200 episodes, which is, by the way, non-stop, we have never stopped, not even for a week, not even for a day. Consecutive episodes, we have garnered 13,100 members and more than 8 lakh viewers. So that's the beauty of iFocus, and we are trying to cover the entire curriculum of ophthalmology. I request Dr. Lalit Verma to introduce Dr. Das.
Thank you, Santosh. I actually, will not introduce TPD because he is such a well-known figure. He does not require. He is actually, to me, he is a giant of ophthalmology in India, and a doyen which everybody knows. One of the greatest, retina figures I have come across in this country. So knowledgeable, so down to earth, and so humble also. And all of us know that he's responsible for, for LVP achieving such great heights. And he has an immense role to play. So many fellows he has trained all across who are doing great work. In fact, LVPI at Bhubaneswar, it was totally his brainchild, and you see how much green covered area, how much light, everything. He goes into such details, micro details, that I remember visiting that place, and the kind of micro management he was doing was a great learning for me. Believe me, all of us at Center for Sight are actually honored and privileged to have Dr. Taraprasad Das. We lovingly call him a TPD. And we are so privileged to have you with us, sir. And believe me, all the listeners, they will enjoy his talk. And as Santosh was saying, endophthalmitis subject is so close to him, and he's written so much about this disease and done a lot of innovative work. As you can see in this one slide itself, that how much recognition he has had. He was president of AIUS a couple of years back, and presently is the vice chairman of LVPI, fellow National Academy, vice president Asia Pacific Academy. In fact, in the entire Asia Pacific also, he is a very, very well known, invited virtually, mostly all the Asia Pacific veterinary societies also. And his research primarily is concentrated on endophthalmitis and diabetes. And as Santosh was saying, Padma Shri is very small honor for him, but he did receive Padma Shri, one of the highest, civilian awards by Government of India way back in 2013, and has so much research grants, 18 research grants published to nearly 350 papers in peer-reviewed journals, and written so many chapters and authored so many books. Sir, we are privileged to have you here. And endophthalmitis, you see, is such an important topic, and I think everybody who listens today will have some carry-home points, and because this topic should be known to all, not only retina, although we are doing it as part of retina series. Endophthalmitis should be recognized by everybody. If not with retina, at least interval injections should be given by everybody. And that, I think, is very, very important. If we have to save eyes, we have to diagnose and treat in time, because time is very, very crucial. So I will not come in between TPD, as we lovingly call him, and the audience for his great talk on endophthalmitis, diagnosis and management. Over to you, sir.
Thank you, Lalit. Thank you, Santosh. Am I audible?
Yes, sir. Yes.
Okay. Now we have to go to the screen. Okay. You can see my screen now?
Yes, yes, sir. Yes.
Yes.
All right. Thank you very much. Thanks, Santosh and Lalit, for bringing me to this this wonderful audience and iFocus. I've heard a lot about it, and a few days ago, I was wondering how things are being managed. But I know that 800,000 hours, lectures, viewers, amazing work they're doing. And Santosh himself goes to so much details about everything that he does and so meticulously does. Thank you so much. Actually, we're honored to be with both of you, Lalit and Santosh. Okay, I do not have any financial disclosure to make related to this.
Can we maximize? Can we maximize slideshow?
Maximize. Okay.
Yeah.
Done?
Yeah, done.
Wonderful. Thank you so much. I don't have anything to declare for related to this presentation. Okay, endophthalmitis is a inflammation of inner layers of the eye with exudation of vitreous cavity, resulting in intraocular colonization of microorganisms. So it starts in the vitreous and spreads out inwards and outwards. So we'll talk more detail as we go on. Histologically, it is a massive infiltration of inflammatory cells. Primary focus is vitreous, irrespective of the exogenous or endogenous, and secondarily affect the retina, choroid, and behind, or the lens in the front. And we did experimental work on a rat model, both the diabetic and non-diabetic, introduced diabetes by intraperitoneal streptozotocin injection. We use 3 common infecting microorganisms, Staph epidermidis, Pseudomonas aeruginosa, and Aspergillus flavus. And we do the histopathology. We see that in a left panel is that all diabetic patients, both in Staph epi and Pseudomonas, there is a much higher inflammation, aggregation of inflammation material compared to the one in the right. However, in the fungi, it is not too much different. So it means that diabetic patients that had infection, they have a larger colonization of the vitreous of the organism, so they might require a different kind of treatment or more aggressive treatment. We classify endophthalmitis broadly into two kinds, exogenous, endogenous. Exogenous after surgery or trauma. Surgery could be again acute or chronic. Endogenous could be diffuse focal, or if it's a too much diffuse or involve entire eye, then we call panophthalmitis. But for this presentation, we will confine to something else. One should know this nomenclature because this is a kind of PG talks. I thought I will include some of this stuff that we call acute. One is a within 6 weeks of surgery. We in early symptom signs are poor media clarity and less visibility of the retina. Bacteria and fungi are usually gram positive or gram negative, and the mode of entry told depending on exogenous or endogenous. And the trilogy of management is like any other disease, that we have to have a diagnosis, then you require a treatment, then finally you will land up in how do you prevent certain diseases like this. For this presentation, friends, we will confine to exogenous endophthalmitis after surgery, usually post-cataract surgery, and acute. The other things will be I might touch upon, but not possible to include everything because of lack of time. Let's begin the diagnosis part. Diagnosis, as Lalit told, is always clinical to begin with. Ultimately, you get into microbiology, but you suspect something. This suspicion comes from 3 or 4 important signs that are vision is reduced, eyes are usually congested, there will be cells and flare in the entry chamber, there will be variable amount of hypopyon, sometimes may not be hypopyon though. There will be exudative membranes, either in the pupil or in the vitreous cavity. There are a lot of vitreous exudates visible. In a surgery which is not phaco, like SIS, you might have a wound gap or something, then it then involve the entire eye called completely no visibility at all. But from this clinical signs and symptoms, one diagnose that this is possible endophthalmitis, then start treatment. Unfortunately, we do not have a currently measurement. How do you measure this? We told that endophthalmitis inflammation, then how to measure it? So many years ago in 1999, we produced a kind of a mnemonic about a chart that how to using this 4 important tissues that we can see in a slit lamp or ophthalmoscopically, cornea, antechamber, iris, and vitreous, in a scale of 0 to 4, when 0 is nothing, not infected, and 4 is highly involved. Divide every tissue into 2 areas, like cornea, example, say clarity and abscess, or vitreous, we say flare and opacities. How do you quantify this scale is currently used worldwide to quantify disease, particularly used in animal models, so that we can quantify the disease. And we have used in a human model also. As you go along, we'll talk about it. Now, looking at that inflammation, we call inflammatory score, as previous slides saw that it can be 20 and more, that the highest is 20 and more. Then supposing you have that idea that 20 and more or less than 20, then you found that days to symptoms are higher, those have got a more than 20 inflammatory score. We also saw that culture positivity is higher in the eyes who have got a higher than 20 inflammatory score. Similarly, gram-negative bacilli grows more in eyes who have got a more higher inflammatory score. Example here, 45 to 70%. And finally, the final visual acuity FVA is always worse in eyes who has a larger inflammatory score like this compared to eyes who do not have a less inflammatory score. To summarize, you have got a faster symptoms, you got a higher culture positivity, you got a higher GNV growth, and then eyes do not do so much well if the inflammatory score is less more than 20. At the same time, because there is a clinical diagnosis, one must know how to differentiate between very commonly misdiagnosed condition called the TASS, toxic intersegment syndrome. It is a sterile postoperative inflammatory reaction, usually happens in the first postoperative day, and this could be because of incorrect pH of the ring-lacted balanced solution viscoelastics, or a toxic contaminant, not infective but certainly are toxic. Or incorrect osmolarity of ophthalmic medicine that is used before surgery, or incorrect IOL cleaning or sterilizing compound that is used. In general, they are cellular necrosis, apoptosis, and extracellular damage. What happens is the eye cornea is completely edematous, and then from sclera to sclera, with the rise of intraocular pressure. And treatment is incidentally very simple, that give a frequent topical steroids plus minus oral steroid. And topical steroids will be frequently instilled almost every 30 to 60 minutes for 2-3 days. Then usually by end of the day, 24 hours, then pressure comes down and eye looking little better. This is a chart we published many years ago, that how to differ between TASS and endophthalmitis. It is always happens on the first post-op day. There is no pain, normally. There is a corneal limbus, cornea is edematous limbus to limbus. IOP is raised, and the dramatic response to topical steroid, which doesn't happen in the endophthalmitis. This simple formula might save a lot of concern to the patient, doctor, and save a lot of money for treatment cost. But then clinical diagnosis is not enough unless we prove microbiologically, because sometimes microbiology might give a different clue than clinical picture is. Normally, we get a specimen. Specimen is intraocular fluid, either interchamberal fluid or vitreous fluid. We do a microbiology workup with a microscopy, culture, and susceptibility, and if required to, then do extended workup like molecular microbiology and or NGS inflammatory markers like this. But we confine mostly to the conventional workup for this presentation. Vitreous microscopy, when vitreous is sent to the microbiology, normally they will do a wet smear with a gram, GIMSA, sometimes KOH, electrophenol cotton blue. You will see a lot of inflammatory cells. And in the inflammatory cells, if you are seeing the group of gram-positive cocci or gram-negative bacilli like this, or a stout ones, or a budding yeast, then you can identify them. Staph, strepto, bacillus, pseudomonas, aspergillus like this. But sometimes it is not possible. But if you are a good microbiologist, then you can certainly, it helps to make a decision immediately. Example, you will not like to give a intravitreal steroid injection if your microbiologist confirm that this is a most probably fungi on the table. But then we also found that despite sometimes, even the microscopy cannot tell you what it is, we also found that in a kind of retro analysis, that higher number of polymorphs in a vitreous smear means most probably culture positivity. Having said that, culture is more reliable than cytology, and vitreous fluid is more important than interchamberal fluid. Oh, it is not moving now. Okay, it's moved. Many years ago, also found out that what is safer way of doing a vitreous tap, and we found that it's published in 2004, my fellow from Cochin called Raju, that you get a 23 gauge butterfly needle and 10 ml syringe, then you can manually suck it. So if you're not doing a vitrectomy, then this is one way of removing the vitreous from the eye, and this is now being adopted many parts of the country or the world. Culture, you have usually three solid culture medium: blood, chocolate, and severods. Blood, chocolate for the bacteria, severods for fungi, and then you had a thyroid broth, brain heart infusion, and Robert Cook meat medium. This is not the form talk of microbiology a lot, but in general, blood agar, chocolate agar is also grown for both aerobic and anaerobic. Others are aerobic. Remember that SDA grows in 27 Celsius, otherwise everything is 37. Bacteria usually grow in a 2 to 5 days time, and fungi 7 to 10 days time, or sometimes little longer. And one has to wait for the fungi to grow. How do you say it is significant? Obviously, growth in one liquid medium, even though sometimes become turbid, could be contaminated, so it should be eliminated like what they've shown here. But otherwise, the growth in a one solid medium is the best one, or growth in more than one media, or one solid and one positive microscopy should be considered significant. And this would be accordingly, microbiologist version of the diagnosis must be taken care of for the following treatment. You do a susceptibility testing either by qualitative or quantitative, either by the Kirby bar was usually done, but nowadays people are shifting to e-test. Both are nearly similar, that you get an epsilon thing or you get a rounded thing, then measure it. They're all antibiotic impregnated, and you find out that what they are. Usually culture take, Pseudomonas might take 2 days, or staph epi might take 5-7 days, and another test, so that by 7th day, usually you get the both culture and susceptibility report for further management if required to. Instead of biochemical test today all over the country, most probably they usually the automated machine called Vitec 2, Vitec 1, Vitec 2 now, that speciation becomes easier and faster, and certainly more reliable and accurate. Having said that, you also should know that some of the common infecting bugs in the eye. Example, for acute post-cataract has to be a coagulation negative Staphylococcus or aureus or Pseudomonas, similarly written here. Let's say for a glaucoma filtration surgery, it should be hemophilia, influenza, and streptococcus are important. For intravitreal injection and steroid or anti-VEGF should be streptococcus, very important organism. Once you know this thing, then most probably treatment is easier, because many times you know that what antibiotic are normally sensitive to this kind of organisms. We should still know them. This is the data which talks about the both gram-positive cocci and gram-negative bacilli, and USA 1 published in 1995 VVS, then India we have taken from the both LVPI data only, either side, and that is some different, but they're nearly matching to each other. But this keeps on changing, and I will, as we go on, I will talk to you how this changed a lot. We found last 25 years, published in 2019 in journal I, that vancomycin resistance or sensitivity to susceptibility remain nearly similar. It was resistant 5% times in 2005, and 2015 is 6% resistant. That means nearly similar. Not much change for the gram-positive cocci. That means vancomycin continues to enjoy a good drug for intravitreal injection for endophthalmitis. The other drugs, septagine, used more often. We found that in LVPI system, that it was sensitive, it was resistant 31% times in 2005, has gone to 60 plus percentage, 62.5 to be precise by 2015, which means that septagine may not be a more important drug for gram-negative infection and endophthalmitis, and we have more evidence talking about it. Having a diagnosis of clinical and now microbiological, let's think about how to treat it. And treatment is always empiric to start with, because we do not know the microbiology report. And guided by the EVS, we will talk a little more detail. You give an empiric treatment, either a tap injection or a bit injection, whichever way. Patient doing well, irrespective of what the microbiologist said, treatment ends there. Supposing the treatment microbial susceptibility is now available to us, is susceptible, and doing well, irrespective of what antibiotic you have injected, the treatment stops here also. In case it is resistant to what antibiotic you are given, but still doing well, I will not suggest you to change because of microbiology reports are different than the clinical decision maker that a clinician is. If not doing well after empiric treatment, or the antibiotic injected are susceptible, still not doing well, or they're resistant and not doing well. So in either case, we'll do a revision of treatment. The revision depends on how to decide. We'll do a vitrectomy again, or injection again, or the both, or something else. The decision you have to make yourself based on your own clinical judgment and also backed by the microbiology report. This is what EBS recommended, that by the presenting visual acuity of more than hand motions or less than light perception, you decide to give a primary treatment should be a tap injections or a wet injection, unless patient is diabetic. Injection is always vancomycin, septaginine, the dose mentioned here. Then normally for a patient with the visual acuity of more than hand motion, no vitrectomy, otherwise do a vitrectomy. But if he has recommended that no systemic antibiotics, no intravitreal steroids, systemic steroid, yes, and an inadequate response, mostly they advise for repeat intravitreal antibiotic, not repeat vitrectomies. Even though EVS actually used amikacin as their drug for treatment, they recommended septaginine because of macular infarction. This is borrowed from my colleague Avinash Patenge, that intravitreal amikacin, even though in the correct dose of this was 400 microgram, given then it caused macular infection. So that is why EVS recommended that use septaginine instead of amikacin for as a choice of gram-negative antibiotic. So there are two antibiotics now. Vancomycin is a glycopeptide antibiotic, acts by inhibiting the cell wall synthesis and active against MRSAs. And septaginine, the third generation cephalosporin, inhibits also the penicillin binding protein cell wall synthesis. Together, given together because two separate syringes, because it prescribed otherwise, because one is against gram positive, one is against gram negative. And I told that we were empiric treatment, we do not have microbiology data to begin with. That is why we act two, but in two separate syringes. And this is how we prepare them. I have the verruconiazole added here because there is another drug used for fungi infection, that you have this, as is shown here, that we draw 1 ml or add 10 ml and add all the things. So ultimately you will get a solution of 2.25 milligram per 0.1 ml of septaginine, 1 milligram of vancomycin, etc. But in a busy clinic like we have Prasad, every day 4 or 5 cases are treated because one lot are referred, and you ask the nurse to prepare them, I'm sure it has happened to me, the nurses will make a mistake. If you make a mistake, then either treatment is excess or low, and sometimes luckily there is no amikacin written here or gentamicin written here. You will have an infection like happened, I showed you from experience of Dr. Patenge. So we found a solution that supposing you make it a little simple for the nurses, eliminate one step. So add ringer lactate, different dilutions of 0.9, 0.8 is gone for antibiotic. Injections, syringes are made uniform, 10 ml for antibiotic. Only the volume of injection change, and then the direction of the nurse is that if it's antibiotic, I'm not talking antifungal, it comes in larger vial, then add 10 ml of water. Withdraw 0.1 ml, give it to me, darling, it will be all right. So to make this as simple, we designed something called EKIT. E stands for emergency. This is currently marketed by Orolab. And that has got the antibiotic we call vancomycin septaginine, has got a verruconazole small ones. They got all these largest 10 ml syringes to use this, and then speculum, all the 3 needles, everything that you need, open it and use it, and then you can dispose it off. Many times, because they come in an odd time, you may not have all the things available to you in the same time. So there is why I designed it so that emergency you can treat a patient and not do it. Many years ago, Lalit and late Professor Tiwari published very wonderful paper in IGO. Very brief communication, but this is very illuminating paper. Most people they refer to AIMS, RP center those days will not have a treatment, but those who had a treatment like intravitreal injection before they land in RP center, they did functionally anatomically better than the eye who did not receive. Which means that even if you are not a retina person, you are not going to finally treat a person who would refer only, please give injection. Then at that time this can be useful, because you will be used maybe twice in a whole year, so you will not able to remember all the injections, volume, etc., etc. All you tell is that take a big vial, take a big syringe, take 10 ml of water, inject into, you drop 0.1, inject it. That's it. Then use the speculum. You want a vitreous sample, you have got a butterfly needle here. All right. Now we have a problem with this, with the EVS recommendations. I have 3 problems that I have circled it. 1, the presenting visual acuity. 2, should we or should we not give intravitreal steroid? And 3, how often or how soon we will do a vitrectomy. Vision part is very simple. The hand motions of EVS was actually not hand motions as Parsons and we read described, or at least I read described. The hand motions of EVS is seeing the movement of the hand 1 meter away, which is equal to roughly 2400. So we thought let us make it 2400, because they will understand. Otherwise, hand motion sometime in a British system of ophthalmology that we read here sometimes be confusing. We'll talk about intravitreal steroid and vitrectomy in next few slides. Now, we say the endophthalmitis inflammation. Infection is caused by microorganisms. Inflammation and macroorganisms together, they cause toxins. They have tissue and damaging enzymes. There's a host inflammatory response. They all lead to a scaffolding, epiretinal membrane formation, vitreous membrane. Even though you treat properly, this membrane may not be able to go away with the treatment, because you're treating only the infection or the inflammation, then there will be a problem. So we said that in that situation, because to treat the inflammation also, you need some kind of steroid, and that could be topical, subcon, oral, intravitreal. Now, endophthalmitis vitrectomy study, they use topical, subconjunctival, and oral. They eliminated intravitreal for whatever reasons. Reasons might be that the fungal infection, but then they did not recruit anybody called fungal infection in the whole study though. We did some literature search, found that published several years ago in 1991 from US that the rabbits which has got a vitrectomy with gentamicin and dexamethasone or gentamicin dexamethasone, they are anatomically, functionally, those retina did much better than the eyes where dexa was not injected. So there are some 20 animal studies. 70% of them say that the reduced inflammation improved ERG function in the small animals, and 30% say that no big difference. And this was studied on host organisms: Staph epi, aureus, Pseudomonas, Streptomyces, Bacillus cereus, Pseudomonas, Escherichia faecalis, and Candida albicans. So kind of all bugs normally infect the eye has been studied. Enough proof of concept that this should work. Similarly, 7 studies, and 6 of 7, 86% say that injecting intravitreal dexamethasone along with antibiotic is good. And 1 study only 14%, that means say that a reduced likelihood of 3-line improvement did not become worse, but 3-line improvement may not happen. We did our own prospective randomized control style. We said that in a post-cataract eyes, those eyes who have a dexamethasone, whether they are culture positive or negative, that inflammation comes down drastically by 1 week and continues up to 3 months. Those eyes who did not have steroid injection, on the first week, they actually go higher, then they start tapering, but any point of time, they're usually higher, which means that intravitreal steroid reduces inflammation, eye is quieter, and without affecting the final vision. So this contention that they may not improve vision is most probably not correct, but it's certainly a fact that this giving steroid helps the eyes, bacterial endophthalmitis eyes, to be quieter, faster, and respond better. Look at the systemic antibiotics. Now, EVS say no systemic antibiotic, they gave actually ceftazidime and vancomycin, but they said not required. And we have a different idea though. Now, why it is not required? Because the most antibiotics, these are available in early 1990s, did not cross the blood-retinal barrier, either aqueous barrier or the blood inner or outer barrier. Now, but in our own study, we found that in uninflamed eye, if the Cipro is given 750 milligram 3 hours prior to vitrectomy, then vitreous will grow, will have a ciprofloxacin of 0.18 microgram per ml, equivalent to, or a blood volume at that time will be 1.06. But 7 given for continuously in inflamed eye and continuously for 3 days, then increases from 0.21 to 0.66, which is higher than much higher than the uninflamed eye. And since it's inflamed eye, oral ciprofloxacin given for longer time, 3, 4, 5 days, might actually work. And the reason it will work is the following: that ciprofloxacin MIC 90 is shown on the left side, and we say that most of the time oral ciprofloxacin, as shown by a couple of studies from US, that they had a higher MIC 90 taking care of all the common infecting microorganisms for the vitreous for the endophthalmitis. So we also have one more experiment, which is published experiment, that intravitreal vancomycin on the day given is very high. By day 2, it comes down 44 decrease. By day 3, almost negligible. That means by 3rd day, we do not have intravitreal injection of the vancomycin or ceftazidime or amikacin, whatever drug we talk about, because they all run away if you could have done a vitrectomy and eye is inflamed. Then what happens? We say that, this is our hypothesis, say that intravitreal antibiotics, after giving injection, this declines, and by 3rd day, it actually goes down below the MIC. At that time, your antibiotic given on the day 1, or day 0, will slowly increase. By day 3, this will go higher, so that MIC is still maintained for the organism to work against. So we suggest that where required, one can give systemic antibiotics. My preference will be fluoroquinolone and oral, because don't have to admit the patient unnecessarily. Finally, we talk about the vitrectomy part. Then vitrectomy in EVS said that debulk vitreous, which creates a space for the IOB and facilitate antibiotic functions. EVS recommendation: do not remove vitreous more than 50%. They call core vitrectomy. And because it might cause retinal damage or retinal detachment, do not induce a PVD. But over a period of time between 1990 and 2022, the gauze size of vitrectomy has come down from 20 to 27. The fluidics have increased and can go closer to retina by 47%. You can have, without interfering too much turbulence, you can create a nice fluid. So we, like Farren Schoon suggested, that a complete vitrectomy, an early vitrectomy, is more useful than a core vitrectomy or a delayed vitrectomy in endophthalmitis. And we suggest the same thing. We look at the study from China. It says that in years between 1995 and 2009, the number of vitrectomies are increasing, number of injections, primary treatment are decreasing. And then also say the same study says that the functional outcome after in later years where there's more vitrectomy is better than the earlier years where there's a primary treatment was only injections. So which means that earlier and complete vitrectomy more useful than delayed or no vitrectomy. Having said that, why all eyes do not do well? They do not do well because of MDR, multi-drug resistant infection, and also the increasing culture negative endophthalmitis that we see. Now, this is how it is that we find between 2010 and 14, we find that ceftazidime of these 200 patients were gram-negative, 34%, and 28 of them were Pseudomonas. The Pseudomonas guys were resistant to 100% time to ceftazidime. That is the problem. That is a multi-drug resistant organism. And we also found that the kinetic of MDR strains are different. They are more pathogenic. The infectivity is higher in multi-drug resistant strain like shown here than the sensitive strains. Then we also showed that the one which is a propagating problem is a biofilm, which forms more in in Pseudomonas multidrug resistant bug. This is published last year actually, and this year we also published that in IJO that the eyes where a biofilm is formed here, they require higher information. B positive means the biofilm positive. They require a more number of interventions. The functional outcome is less. Anatomical, so this is anatomical outcome is also less, and log vision is also less, which means that multi-drug resistant bugs are a problem. So what is the alternative then? Alternatives are, there are two right now to my mind for gram negative, because as I told, vancomycin is a good drug still, are imipenem and colistin. Colistin is a polymyxin class antibiotic. It also works from the MDR gram negative bacteria, and to my mind, it is better than imipenem, and the drug is written down here how to use systemic, topical, or intravitreal. We also found that over the years, in 25 years, our culture negative infection has grown from 50% to 69%. Either our microbiologists are not good or our bugs are smarter. Actually, bugs are smarter. Our technology is behind that. We are not using the right technology. If you use a PCR and next generation sequencing, this data we are just working, not yet published, that in our 182 consecutive patients, culture is only 33% positive. If you combine the PCR becomes 63, it becomes NGS 100%. This is a one sample of culture negative PCR positive bacteria. Did NGS, and all the NGS are positive. What is good to see here is that they do not go normal culture, because most of them are mixed infection. Unlike one or two of them, they are mixed infection. Because of mixed infection, they compete with each other and do not actually grow in a culture. Talk quickly about the prevention. We know from 1991 publication by Mark Speaker that use of betadine, either 5% for the conjunctiva or 10% for the lid and skin around it, has shows a reduction of 4.5% of post-cataract infection, and which is now almost a standard of care all over the world. In 2006, ESCRS also published that giving intracameral cefuroxime 1 milligram 0.1 ml reduces nearly 5 times reduction of endophthalmitis in their patients. Published paper in 2006. We published many years ago in 2002 that there are other drugs, intracameral drugs, other than cefuroxime. There are cefazolin, moxifloxacin, and vancomycin. We use vancomycin here. We found that stap epi with a higher CFU per ml or lower, if in contact with vancomycin, that it reduces completely, which means that the contact of antibiotic with the IOL is helpful in reducing infection inside the eye. Arvind published a study that use of moxifloxacin instead of cefuroxime reduces endophthalmitis by 7.5% over a period of time. And we did actually a study called EPS, standing for endophthalmitis prophylaxis study, where we compared intracameral cefuroxime and moxifloxacin in this number of patients, consecutive patients. Reduction of infection because of intracameral injection, whether either of them is 3.5%, by specifically cefuroxime by 3x and moxifloxacin 3.4 or 4x. So not very statistically significant, but anyway, intracameral works. Cefuroxime is no better than moxifloxacin. Moxifloxacin as good as cefuroxime, because moxifloxacin available commercial in India and cheaper than cefuroxime. So moxifloxacin might be a choice. We did the All India survey few years ago, and we published that 40% Indians by 2017 survey are using regularly intracameral antibiotic. 46% of them use only high-risk patients, but whenever they use it, 78% of them use only moxifloxacin. Others are maybe cefuroxime or sometime something else might be using, but this is what our survey says that. But India endophthalmitis is different, and you should understand this. This is a source about the microbiome spectrum of EVS, 94% gram-positive cocci, 6% gram-negative bacilli. Europe, ESCR, 87% are gram-positive cocci, and 7% are polymic infection. In India, however, This is only 47% gram-positive cocci, 27% are gram-negative bacilli, 10% are 16% are fungi, and 10 are polyinfection. This is very important. How does it actually go forward? We are not alone. We study also from other countries, China and Singapore and Asia. So the similar thing that fungi is a fact, and you can't ignore it. Gram-positive cocci not as high as shown in Europe or US. It is different in Asia and India. And we are not alone. It was the same story in Madras or Hyderabad at different period of time that gram-positive cocci never crosses more than 50%. That means our treatment has to be different than what treatment EVS or somebody else suggests. So that depends on where you are and what we are doing. Other problem in India is the cluster infection. We don't publish too much. We don't talk too loudly, but then once in a while it happens. Then this is what happens in newspaper, that hospital that blinded 10 people. And then many things happened. Somebody in Trichy went to jail. Somebody in Indo, something else happened. Then a lot happened. But this issue, I have not have the data right now with me, but this published no, not this issue. We published editorial some time ago that cluster infections should not stop in only treating the patient, but something more. That's something more is finding the cause, and we use a different kind of technology called molecular microbiology, like a fluor amplified fragment length polymorphism or ERIC PCR to find out. And our data says that if you identify these two actually happen in our own campus, Hyderabad campus, and you identify the cause of infection. The first one was in that inner tubing of the fecomulsification. Next one is in the fluid of the intraocular lens, and we corrected them, and most patients did well, though I don't have the data right now to show you. We already published papers there. Good part is that over a period of from 1920 to 2010, the 100 years time, infection rate all over the world has come down, including India. I have just highlighted three areas where published from Arvind, published from Tirunelveli Arvind, and published by us that it is less than 0.1%. And actually, if you go to culture positivity, it will still be half of it or so. But I have taken the clinical endophthalmitis. So this happened because we understood the disease well. We had a better treatment. We are able to manage well because of EVS data and all our wisdom of microbiology. So I'm just in time. So most of the thing that I spoke to you, my friends, is from this compiled book called Endophthalmitis Management, which we published, I think, a couple of years ago. And I can be reached beyond today's meeting by this couple of these emails if you want to use it. Let me thank again the Santosh, Lalit, and entire iFocus group, and the organizers behind it, Center for Sight, for this wonderful opportunity. And AIOS has done very well, and I know that Lalit has taken a lot of lead in controlling infection or taking care of things, not to allow people to get into harass. And I think this kind of movement will continue, and wherever I can, I will also help you to join. Thank you so much. I am on time, Mr. Lalit.
Yes, sir. Yes, absolutely, Dot. So one of the most illuminating talks, I must say, in the shortest possible time of around 40 minutes, PPD has covered right from basics of definition and experimental work he did, and EVS, and personal data, everything, including prevention. All the things have been very, very well covered. I, for one, do not have any question, but I would love, any questions Rolika or any other people have. So I just read on the chat box, actually, yes. Antibiotic and dexamethasone intravitreal injected simultaneously. Will the steroid flare up infection? I think TPD did answer this. Can you, sir, please take it again? Antibiotic and dexamethasone, if you are given simultaneously, will the steroid flare up the infection?
No, it does not. That's what I'm talking. It does not. And irrespective whether you give antibiotic first or dexa first, but it will be 3 different syringes, it does not flare up. EVS was most probably scared of that, but then we have shown beyond doubt. And not only you, and not only we, example, and entire Bascom Palmer, my good friend Harry Flynn group, they published a huge paper about this in ophthalmology several years ago, that why it should be given. There's enough rationale. I saw that why steroid is a good rationale for treatment of endophthalmitis, because inflammation is not taken care of by antibiotic alone. And the dexamethasone, that dose, 0.1 milligram does not harm the 0.4 milligram doesn't harm the eye at all.
Only in patients who have fungal infection or clinically, or there is suspicion, we do avoid giving dexamethasone.
Yes,
No,
that
sir.
is absolutely true. That is why microbiology is important. Suppose you get a smear result immediately, fine. But several years ago, while you are doing the prospective study where Ajit Babu also was a part of it, few patients were later on found to be fungal infection, actually inadvertently given dexamethasone, and two-thirds of them did not, were still all right, and nothing harm happened. But I will certainly agree with Lalit that fungal infection will not give. Now, acute infection, Lalit, will not be definitely caused by fungi. There's hardly. They usually come after 7-10 days, a smoldering infection, little hypopyon. You can some more of vitritis than more of interchamber reaction. Then so you can invariably by clinical experience and find out. But having said that, if you're in doubt that you might be harming the eye by giving intravitreal dexamethasone, no harm. Not giving it. But the moment you confirm that there is no fungal infection, should be given. Otherwise, long-term harm, because the epiretinal membrane formation and vitreous doesn't clear as quickly. There's another paper, we did not talk about it, that how giving many injections, it happens in a fungal infection also. Even triamcinolone injection can be given. It published in AGO by Avinash and me. So it doesn't harm at all.
So other question which is actually not relevant for this talk is about metastatic endophthalmitis, because the thrust of this talk was primarily, exogenous post-cataract surgery endophthalmitis. But someone has asked, how do we treat metastatic?
Yeah, endogenous endophthalmitis, we mostly by fungi, and we recently published in IGO that if it's a COVID infection, mostly Candida, otherwise not always Candida. And we also published several papers on that. But I thought, given the time, instead of talking everything, talk one and talk more clearly. But maybe some other time, or I can personally give my answers or refer to my papers, published papers though.
Any other question, Rolika?
Yes, sir. Yes, so the viewers have questions, and that is like people asking on YouTube that can aspergillus be found in endophthalmitis before 7 days?
Come again? Aspergillus.
Can aspergillus be found, like endophthalmitis due to aspergillus, be found earlier than 7 days duration?
Well, everything is possible. I have a patient who has a mixed infection of fungi and bacteria, but happened on the day 2 or 3 of surgery, because there's also a mixed infection with bacteria. And today that can always happen, but outliers are always possible. But the normally not.
Yeah, Rolika, but fusarium is known to present as acute also. You see, more than aspergillus, fusarium can present as within few days also, because that I have seen.
Right, sir. And it also has a north and south correlation, sir. Is that also true?
We published a paper last month, month before, in ophthalmology retina, that aspergillus, fusarium, not nocardia, and candida distribution in the country. The earlier paper from Chandigarh, the largest paper before we published was aspergillus was highest in Chandigarh by Chakrabarti, but not really always true though. And that paper you can refer to, fungal endophthalmitis paper published in Retina, I think 2 months ago. There are 730 patients taken from Chandigarh, Delhi, Chitrakoot, Hyderabad, Madurai, Madras, Pune, Guwahati, Calcutta, like that. So that has got a geographical distribution of the infection, both in a endogenous, then exogenous, trauma and post-cataract.
Yes, sir. As per their study itself, it was that aspergillus will be more in north and fusarium will be found more in south.
Aspergillus infection is certainly more Endophthalmitis fusariae more in keratitis, agreed. But we cannot ignore also Candida, particularly those who are immunosuppressed, diabetic, and long-term steroidic, antibiotic taking, they also might have Candida infection. In fact, Candida infection is a little easier to treat compared to other bugs.
True, sir. And so one of the viewers have a question for clarification of the intravitreal dose of voriconazole. Would it be 0.05 milligram per 0.1 ml or 0.1 and 0.1?
50 to 500 microgram, depends on what you want to do.
So it's a range.
Yeah.
Right, sir. Another question is that can scleral buckling cause endophthalmitis, or it's more of surface and buccal infection? How do we deal with it? And especially because buccal will have to be removed.
It is a local infection. Unless sclera is perforated, it will not cause infection inside the vitreous cavity, local infection. And we have published 2 papers on this, on Microbiological Siloni and other bugs affecting it. But once you treat properly, remove it, then usually the guys do well. And since it happens years after, removal of buccal does not cause a retinal, re-retinal detachment.
Right,
so. Buccal per se, still buccal is not the culprit. The culprit is generally, you see, inadequate or inappropriate suturing or some gap somewhere. But if you remove that buccal, generally it's therapeutic because the surrounding, infection there, which forms a shell more or less there, it does respond to buccal removal.
Unless a perforated will not cause endophthalmitis, it's a local infection. And usually exposure, long exposure to conjunctiva, open gap, conjunctival gap actually causes all this kind of problem.
The other thing is fear of redetachment in these patients is generally nil.
Yeah.
Because they present pretty late. And people are generally scared that buccal nikalenge to dobara attachment to that generally.
Yeah. Both our published paper had a different organism, so strains were different, but then no I have had a recurrent detachment. TPD,
one query or one clarification. See, you showed very elegantly the increasing role of vitrectomy. You were referring to one Chinese study that functional prognosis also improved, and the percentage of eyes being subjected to vitrectomy with the smaller gauge and safety of vitrectomy has increased overall. So in this era, do you ever recommend giving a second interval injection? Suppose you have given one, patient response is not good, and do you still recommend giving a second interval or jump to vitrectomy?
Well, question is that supposing given a primary was a injection, then second injection talking about or something else?
Yeah. First injection has been given and response is not good.
No, I will not jump because anytime conservative is always better, but then fear that vitrectomy should not be done is not very correct. Many times Lalit don't do vitrectomy because if the patient come in odd hours, spend more money or more time. But vitrectomy is certainly easier today because of 23-25 gauge and what I started in many years ago. Between the two, between intravitreal injection and vitrectomy, if the presenting vision is not good, then I will prefer a vitrectomy than so my answer is, answer to an important question. Supposing there is injection given as a primary, then doesn't work, I will prefer vitrectomy. If vitrectomy done and doesn't work well, I'll prefer injections.
Yeah. Ritesh, you have any point regarding this question?
Yes, sir. Rightly, as sir has put in, threshold for doing vitrectomy has definitely gone down. So from 2007-8, when I was doing my fellowship to now, we are doing a lot more complete vitrectomies, lot more PVD inductions. And yes, second intravitreal is rarely being used unless until you get a good response with the first and then you're continuing the therapy.
Yeah. So that's what I was saying, the threshold of going inside and doing a total cleanup, I think has increased quite a bit.
Now also, second injection, Ritesh, should be based on your antibiotic sensitivity.
Yeah.
Supposing it is same, same, let's say septa venco, that is fine. But my worries are that septagidine is increasingly resistant to many of the gram negative, and we have almost 25-27% of gram-negative infection. So I wonder whether someday we'll switch from septa to something else. That's something else, as imipenem or piperacillin or colistin, I do not know yet. But when you become president, call a meeting, have a consensus on what antibiotic India should give. Let us not keep on following because of EVS told me to do so.
In fact, that what Ritesh was saying, that was my second question which I had in mind, because based on the different isolates in India vis-a-vis US or Europe, I think we should not be blindly following that. That is point number one. And secondly, why not? You see, because the sensitivity pattern of ceftazidime is not favoring the common organisms. Why not? Vanco, let Vanco be there. But for negative, I think we should be shifting rather than giving. Till today in India also, Vanco Kefta is the most used combination. A lot of people have asked, in instruction course, and why not shift to Vanco plus imipenem?
That is why I should have a white paper on India recommendation for us, not for other part of the world.
Yes.
Because we do roughly 6.75 or 7 million carotid surgery in a year. If in a 0.01% infection, we'll have a 1,700, 2,000 endophthalmitis in a year. It doesn't matter how you do it. So how do we save all of them, or at least 2/3 of them? And if 25% are gram-negative infection, they're talking about something like 750 patients in a year, or that many eyes. How can we save it?
The other reason is gram-negative more destructive also. So therefore, we can't afford that we give ceftazidime and then switch on to more potent drugs.
They require earlier intervention, maybe vitrectomy faster than otherwise, than gram-positive. So I am giving a June work. I'm giving ahead of time. Since you are retina guy, well, I hope that you will do it.
Yeah. Rolika, any more questions from?
Yes, sir. So one of the viewers want to ask that you told about the range of intravitreal voriconazole. Can you please be specific in aspergillus? What would you prefer?
Well, I do not know what I will prefer, but between voriconazole and amphotericin B is more killing than otherwise. So there is one published paper where we called M4V, where a combined amphotericin B and voriconazole are given alternately. They work better in a resistant fungal infection. I will not worry too much about 550 micron, 100 micron, because either side is safe. And I will not worry about aspergillus or candida or fusarium. I will prefer to stay with whatever I like. I will prefer to give 100 microgram than 50 microgram.
Yeah, Rolika, we generally give 100 microgram of voriconazole in a patient who is suspected of fungal. And I have rarely used combination of M4 and Vorio.
Very rarely, we just with one patient, two patients actually did not respond after several attempts. So ultimately, that is Avinash actually idea. And a few days from now, actually, entire African country, I'm speaking on fungal endophthalmitis. So maybe I will pass that information to you, and then you can use that or the link to you, and people can hook to it if they want.
Even oral voriconazole, we start using as soon as because oral voriconazole also has good penetration inside the vitreous cavity.
Expensive, but is better. The difference between M4 and voriconazole is that amphotericin is more expensive and difficult to prepare compared to voriconazole, and also intravitreal voriconazole, amphotericin B only possible, not oral. So between the two, I will try voriconazole first because it's easier. No admission required. If not working, then I might switch to amphotericin B also.
Ritesh, you had published something recently in COVID era, some fungal infections. Yeah, any throw some light?
So we had the series of candida infections post-COVID, which we had published. And these are all against prolonged steroid user who had immunosuppression and had been on IV admissions and was in ICU. And then they developed these opportunistic candida infections.
Right.
And since they were all very low immunity patients, most of them landed up having vitrectomy. And we were able to salvage, I think, 4 out of the 6 eyes, and with good visual acuity recovery. but they all eventually needed vitrectomy, silicone oil, and all
Exactly.
these
In our own paper, Lalit, 24 or 31, you could salvage, but many of them required vitrectomy and silicone oil.
Yeah.
But
Yes, so
silicone oil actually come from your group. Actually, we should
silicone
all
oil was accidental, once in an emergency in RP center, we were operating and created a break there. So since break created, we had to, clean up maximally and then put oil. So to our surprise, that eye not only got saved anatomically, but functionally had 6x60 vision. So that enthused us that silicone oil can be used. And now world over, in fact, the usage has increased quite a bit.
Absolutely. Yeah, very correct.
Yes, Radhika, last any one or two questions?
So one of the questions probably one of the viewers is asking based on their experience, that is can a very small piece of linen in the anterior chamber cause endophthalmitis, and what is a precautionary measure in such a case?
Small piece of
linen. I think they mean intraocular.
Well, that can cause either TASS or invariable infection, because linen could be sterile, so it can cause a TASS, but then we should take all the precautions to prevent it. We should not talk about removing linen from the eye, etc., etc. And we should not talk about that. But yeah, it can cause TASS infection either.
Right. So that does bring us to one of the questions by one of the doctors is saying the treatment for TASS, what would it be? Clinical features, clinching the diagnosis and differentiating from infective, especially without culture, and when it's dense uveitis.
Well, 2000, I don't remember now, 2003 or 4, sometime published a paper in JCRS that in that series, 27 patients we suspected, and because all at that time we admit patients, now we don't admit patients, so difficult. And what we did was, Rolika, that's it's 8 in the morning, we will suspect infection, but we will give it a try, because OR will not be ready before 4 or 5, like silicone oil accidentally happen. Till 4 or 5, we'll keep on giving steroid, topical, every half hour or 1 hour, something predecetate only. And 3 o'clock, we will see. That means that many hours, 6 hours, we are given drops. If the cornea clears, intraocular pressure come down, okay, thanks a lot, it is not infection. So not worry if you lost. So in that 27 patients, 2 patients had to go to the OR, and one of them are culture positive only. We didn't do PCR in that day. So that is the treatment. So if you are not very sure, but if your own patient, don't get panicky, start giving this topical steroid for a while, but it has to be in the day 1, not referred patient from somewhere else, which is already day 3 or day 5. Then you can try this stuff. And then also do investigate to rule out, to eliminate all those toxic substances that might be entering the eye, so that they don't have heart attacks next day or next time. But this is to your patient. I don't think referred patient will be a TASS. But by the time they referred, will be all, at least a day lost, right?
Yeah. Because TASS is an immediate presentation.
Right.
Immediate presentation.
Immediately. Open the eye,
toxin will immediately, cause harm to the cornea. Therefore, you have entire cornea edematous and pressure is high, and so that you see frequent drops. Steroids will tilt the balance one way or the other.
So
very frequent drop, very frequent drops.
Want to make a point here, sir. When patients, generally the doctors have a tendency to diagnose TASS for their patients more than infection.
Yeah.
So just a small humble request, if you feel it's TASS, at least keep him very close monitored throughout the day.
Yeah.
And don't let him go away from your eye.
Yeah. Now we used to do every half hour slit lamp exam, and every half hour apply drop, see the eye, apply the drop, see the eye, apply the drop, and that is the only way. You are absolutely correct that if you referred by Ritesh to me, oh, infection hoga ye, is my own patient, ho hi nahi sakta infection. That is a usual human tendency, and we should not get trapped into that also. So
Rolika, once you're starting steroid, the same day, like the TPD was saying, every half an hour, but don't allow the patient to go home. Tell him that, he will be sitting there and morning, afternoon, evening, and this will dramatically alter the course. And also prepare yourself mentally, physically, patient-wise, that you have required to go to OR, you'll go to OR and do a vitrectomy also, or at least give injection, if nothing else. Very important point is how to, talk to a patient and family once he develops this. let's say, another subject actually, but you have to empathize with the patient and tell him the mechanics of infection, tell him that his cooperation is required, tell him that early intervention will probably save the eye, save the vision also. Because, once you are in the OPD and you will have one patient landing up, the whole thing will go haywire. So you have to talk, and talk.
That's true, sir. That covers all our questions on all the social portals. Thank you, TPD sir, for such a
right on
wonderful
time.
lecture.
Santosh has arrived.
Thank you so much. Thank you so much. We had a big opportunity.
We had a wonderful, truly wonderful talk by TPD.
I was nervous whether I could be able to satisfy Santosh because he's a kind of बाल का खार निकाल के देखता है वो.
But Santosh, I think TPD did a great job covering, starting with small basic things like, we were asked in rounds, definition kya है endoscopy, and comparing with EVS, Indians, सारा कुछ sir ने cover किया. Fantastic, TPD.
I think we should have our own what do you call that, regime of not necessarily following always ESCRS or EVS. They're good, no doubt about it. But then what is specific treatment we will give for our patient, very important. And similarly, avoid all kinds of cluster infection, whether it's eye camp or eye hospital. Very important. It's so damaging, those things happening to us.
So with this, I think we, on behalf of the entire CFS team, Santosh, Rolika, Ritesh, and all the listeners, we thank TPD for sparing this time and honoring us by,
Lalit, I am honored.
Thanks a lot. Thanks everybody. And see you
soon. Take care. Thanks a lot and good night for all of you. Have a nice Friday evening.
Yeah, same to you, sir. Thanks a lot.
Thank you, everyone. And we will be meeting us all again on May 4th. That will be the 201st lecture of iFocus, a special lecture that would be the vitreoretinal interface disorders, macular hole, epiretinal membranes, and vitreoretinal traction by Dr. Lalit Verma, sir. So we all are hoping you all to be there.
Sure.
You all.
Thanks a lot. Thank you.
Good night.